Assalamu alaikum warahmatullahi wabarakatuh. Today's paper is a retrospective study done by an Australian group and published earlier this month. Their aim was to determine if changes in CBCT slice thicknesses influence the diagnosis and volumetric assessment of periapical lesions and whether these effects vary with lesion sizes. So the scans were taken with the patients had periapical radiolucencies originally acquired at 0.125 millimeter slice thickness, and each scan was reconstructed at six slice thicknesses. First one being 0.125, second is 0.25, the third is 0.50 to then 1, and then 150, and then 2 millimeter. With the slice interval matched to the slice thickness, and the lesion volumes were measured using the semi-automatic segmentation and mimics, and classified using the CBCT periapical volume index, which categorized them from the smaller lesion sizes to the six. And 40 lesions, eight in each group from 2 to 6, were analyzed. Lesion detection rate and volume differences across slice thicknesses were assessed using non-parametric statistics, fragmented with Bonafroni correction. For the result, all the lesions visible at 0.125 mm slice thickness were also detected on the 0.25 mm and 0.50 reconstructions, but detection dropped at the thicker slices, which equals to 92% at 1 mm and 70% at 1.50 mm and 67% at 2 millimeter. And all large lesions for the index were categorized from 4 to 6, were detected at every slice thickness, while diagnostic failures occurred only in small and medium lesions, where they categorized them from 2 to 3, with some two size lesions completely missed at 1.50 and 2 millimeter. So the lesion volumes were significantly underestimated at 1.50 and 2 mm reconstruction compared with the 125 to 1 millimeter. And the volume variability was greatest in small lesions, up to 100% differences for the index category of 2, but generally less than 20% in large lesions were detected for the ones who are in indexed 4 to 6. So a slice thickness of 0.50 is needed for reliable detection of all periapic lesions, while slice thickness up to 1 mm is acceptable for larger lesions, and thicker slices can cause both missed small lesions and significant underestimation of the lesion volume, which may lead to incorrect conclusion about healing or progression when comparing serial CBCTs with different protocols. Therefore, standardizing the CBCT slice thicknesses between pre and post-treatment scans and interrupt any volumetric changes in the association to differences between these slice thicknesses. Although for my opinion of this article is that the study utilizes the patient's real CBCT data and included different sized lesions, which enhances the clinical applicability of their finding. Although I think this approach is common clinical imaging research correlating the CBCT findings, adding histology to it would have more provided definitive benchmark for the diagnostic accuracy. And thank you.